It's time for the 3-question warm-up for Cardiovascular 22. Let's get going. Identify the hepatitis B status of each of the following patients based on their hepatitis B serologic markers. So the first one, negative surface antigen and positive surface antibody and core antibody. This is the recovery phase. Second one, core antibody positive, but the others are negative. This is going to be the window phase. Next one, positive surface antigen and positive core IgM. That's going to be acute disease. Next one with a positive core IgG. That's going to be chronic disease. And the last one with positive surface antibody only. That's going to be a patient who has been immunized. Next question. Which tumors arise centrally in the lung and are linked to smoking? And then which tumors tend to arise peripherally in the lung? So which tumors first are central in the lung and are linked to smoking? Those are your S's, S for smoking. So that's going to be squamous cell, small cell, smoking, central, all the S sounds. Now, which tumors tend to arise peripherally in the lung? That's going to be adenocarcinoma and large cell carcinoma. Next question. A 20-year-old man contracts influenza, then presents with an idiopathic hyperbilirubinemia. What is the most likely cause? So this is a classic scenario for Gilbert syndrome, so you need to know that one. All right, so that's going to be it for the warm-up. Let's get to that lecture now.
Ground control to Major Tom. Commencing countdown, engines on. Oh, you caught me. I like to come up here sometimes between videos. You know, kind of relax and clear my head. Hey McInnis, wait up! Oh, I don't feel so good. I let Dr. Lewis tag along sometimes, but he gets kind of space sick. And on that note, I guess it's time to get started with the lecture. See you back on Earth.
Welcome back. How'd you get down here so fast? How'd I get down here so fast? In this video, we're going to talk about a grab bag of cardiac pathologies, including rheumatic heart disease, pericardial disease, and finally a couple of cardiac tumors. So let's start with rheumatic heart disease. Rheumatic heart disease is a consequence of a bacterial infection, but it's actually an autoimmune phenomenon. This is where you have strep throat, group A beta hemolytic strep pharyngitis, strep pyogenes. And one possible outcome of an untreated group A strep infection is acute rheumatic fever. So your body fights off the acute infection, but then a couple of weeks later, you get autoantibodies that attack the heart and other organs. So it's a type 2 hypersensitivity. There are actually 4 possible non-suppurative complications of group A strep infection. There's scarlet fever, which is where you get a widespread sandpaper rash all over the body, usually while you still have the strep throat. This is toxin-mediated. There's post-streptococcal glomerulonephritis, which is an immune complex-mediated type 3 hypersensitivity that causes hematuria and proteinuria and renal insufficiency, usually 1 to 6 weeks following a group A strep infection. There's acute rheumatic fever, which is a type 2 hypersensitivity where the autoantibodies are directly attacking the tissues, usually 2 to 4 weeks after a bout of strep pharyngitis, mostly in kids. And then there's strep toxic shock syndrome, which is more likely to follow a group A strep skin infection or sometimes a vaginal infection, but sometimes strep pharyngitis can lead to it. Now we're going to lay all those aside for right now except for acute rheumatic fever because that's the one that affects the heart. So let's go over the diagnostic criteria for acute rheumatic fever in the study guide. These diagnostic criteria are called the Jones criteria. First of all, you have to have evidence of a group A strep infection, like an elevated anti-streptolysin O titer, plus either 2 major criteria or 1 major and 2 minor criteria. And if you have either of those, that's going to give you a high probability of rheumatic fever. The major criteria spell out the word Jones. So the J is for joints, which is a migratory polyarthritis. Then you draw the O in the shape of a heart, which tells you this is pancarditis. Rheumatic fever will cause endocarditis, myocarditis, and pericarditis all at the same time, so we call that pancarditis. N is for nodules, which are painless subcutaneous nodules. The E is for erythema marginatum, which is a serpiginous rash on the skin. Now, serpiginous means creeping or spreading. It starts small and it creeps outward like large irregular rings. So these are ring-like rashes that can appear and disappear over a few hours. So they come and go. It's also called erythema annulare, like an annular lesion, a ring-like lesion. And then Sydenham chorea is a chorea of the face and tongue and upper limbs. Sometimes it's referred to as St. Vitus's dance. So either S term will work. St. Vitus dance or Sydenham chorea. So these are choreiform movement, rapid, writhing, uncontrollable movements, primarily in the face and the tongue and the upper limbs.
Then the minor criteria are less important to know. They spell out the word peace. So the P is for the prolonged PR interval, the E is for elevated temperature or fever, the A is for arthralgias, and then technically the C and E go together. So C is for elevated CRP and E is for elevated ESR. And if either of those is elevated, it counts as only one minor criterion. So again, evidence of group A strep infection plus either two major criteria, which is the Jones mnemonic, or one major and two minor criteria, which is the Peace mnemonic. But you should definitely know the major criteria.
Now, in terms of the heart disease, patients with rheumatic fever might have myocarditis that can be potentially fatal, but more commonly, the patient's going to survive and they're going to have autoimmune damage to the valves, most commonly the mitral valve, but it could be the aortic valve. We talked about that when we talked about heart murmurs. You can have mitral regurgitation as an early lesion, and then it can progress to mitral stenosis. Now, on labs, you can also see elevated anti-streptolysin O titers. So the heart disease with elevated ASO titers is probably going to be rheumatic heart disease. And then histologically, you'll see Aschoff bodies, which are pathognomonic for rheumatic heart disease. Aschoff bodies are little inflammatory nodules within the myocardium where you have areas of fibrinoid necrosis infiltrated by lymphocytes and multinucleated giant cells. So it's a type of granuloma. You can also have Anichkov cells, which are activated histiocytes with an owl eye appearance. Next, let's talk about acute pericarditis, which is inflammation of the pericardium, that sac around the heart. So there are lots of things that can cause pericarditis, and there are different types of pericarditis. There's fibrinous pericarditis, which can be due to uremia or renal failure, or it can be due to rheumatoid arthritis, or due to Dressler syndrome, which is that pericarditis that occurs several weeks post-MI. There's serous pericarditis, which is caused by non-infectious inflammatory diseases like lupus or rheumatic fever. Remember, we said rheumatic fever causes pancarditis, which involves the pericardium. But on your test, they might give you a patient with the classic presentation, pleuritic chest pain and a friction rub. Then they would have to give you something else to lead you to a specific diagnosis, like a positive ANA, which would suggest lupus pericarditis. Then there's also suppurative pericarditis, which is where you have an infection of the pericardium and pus in the pericardial space. That's what suppurative means, pus forming. Sometimes you can have hemorrhagic pericarditis due to tuberculosis or malignancy, specifically melanoma. For whatever reason, melanoma likes to metastasize to the heart. It goes to lots of different places, but it's one of the more common cancers that causes cardiac mets. Now, what does acute pericarditis look like clinically? Well, it often causes pleuritic chest pain, which is sharp pain that gets worse with inspiration, and it gets better when you're sitting up and leaning forward. On exam, these patients can have distant heart sounds. You may also hear a friction rub, which sounds like a rhythmic sandpaper or leathery sounds on auscultation. It's kind of hard to describe, but the first time you hear one, you'll probably be like, what on earth is that? And then somebody will tell you it's a friction rub, and you'll be like, oh, I got it. And then on EKG, you're going to look for diffuse ST segment elevation. So if you see ST elevation in a specific pattern, like ST elevation in lead 1 and VL, that's a lateral MI, right? Or ST elevation in leads 2, 3, and AVF, that's an inferior MI. But if you see diffuse ST elevation in all 12 leads, that's not an MI, that's pericarditis. You can also see diffuse PR segment depression, so be aware of that. And then finally, pericarditis can either resolve without scarring or it can lead to chronic constrictive pericarditis. One of the most common causes of constrictive pericarditis is lupus. Now, chronic constrictive pericarditis will cause all those same findings as the other types of pericarditis, but you're also going to have Kussmaul's sign. Kussmaul's sign is when you have jugular venous distension during inspiration. I'll go back to that for a moment, but for right now, just remember JVD during inspiration. Now, what normally happens when you take a breath? Intrathoracic pressure drops, and the right ventricle fills. So normally, the jugular veins would be flat during inspiration. So jugular venous distension during inspiration is abnormal, and that's Kussmaul's sign, and that's due to chronic constrictive pericarditis. Let's talk about cardiac tamponade. Cardiac tamponade is where there's excessive fluid in the space between the myocardium and the pericardium, either blood or a huge pericardial infusion. And that fluid is compressing the heart, preventing the heart from being able to expand and fill during diastole. Tamponade leads to decreased cardiac output and equilibration of diastolic pressures in all 4 chambers. Because of this, the patient is going to have hypotension, increased venous pressure in JVD, distant heart sounds, increased heart rate, and pulsus paradoxus. So, what's pulsus paradoxus? Pulsus paradoxus is an exaggerated decrease in the amplitude of the systolic blood pressure during inspiration. So what on earth does that mean? Well, this is kind of a tricky concept for a lot of students, so let's break it down. During inspiration, your intrathoracic pressure decreases. Blood fills the right side of your heart, first the right atrium and then the right ventricle, and this kind of pushes the interventricular septum over toward the left a little bit. So the left ventricle is going to be somewhat smaller during inspiration than during expiration, since that septum is being pushed over during inspiration. So if the left ventricular volume is smaller and you're pushing less volume out of the left ventricle, systolic blood pressure is going to be very slightly lower during inspiration. And that's a perfectly normal phenomenon, to have lower systolic pressure during inspiration. But this phenomenon is exaggerated with pulsus paradoxus. So again, pulsus paradoxus is an exaggerated decrease of the systolic blood pressure by more than 10 millimeters mercury during inspiration. So it's a drop in the blood pressure by more than 10 millimeters mercury. Up to 10 millimeters is considered normal with inspiration, but if it's more than that, that's pulsus paradoxus, and that's a sign of cardiac tamponade. Now, it can be a little tricky to measure because you kind of have to measure the systolic pressure during expiration and then measure it during inspiration, but if you find pulsus paradoxus, think about cardiac tamponade. Now, pulsus paradoxus is kind of similar to Kussmaul's sign because they're both a slight change in physical exam during inspiration, and they both deal with pericardial disease. So let's look at number 5 in the study guide and compare Kussmaul's sign side by side with pulsus paradoxus because they're similar but they're not the same. Kussmaul's sign is when you have jugular venous distension during inspiration. It's a right-sided heart problem. You inspire, but you're increasing jugular venous distension. Pulsus paradoxus is a decrease in the systolic blood pressure of more than 10 millimeters during inspiration. So both of these are occurring during inspiration. When you inspire, again, you're going to increase blood flow to the right side of the heart, but what results beyond that is different. The mechanism of Kussmaul's sign is decreased capacity of the right ventricle. With pulsus paradoxus, it's decreased capacity of the left ventricle. And the disease that causes Kussmaul's sign is generally constrictive pericarditis. Pulsus paradoxus is much more commonly due to tamponade. So don't get tripped up by that on your test. Know the differences between these two. So what kinds of things can cause pulsus paradoxus? Well, anything where you have exaggerated inspiration. Just makes sense. Exaggerated inspiration leads to exaggerated filling of the right side of your heart, and exaggerated decreased filling in the left side of your heart, and a decrease of blood pressure with inspiration. So we see it with cardiac tamponade, we see it with asthma, with croup, with obstructive sleep apnea, with severe COPD, and then rarely with pericarditis. Remember, that's less common. And then one other thing to know is that the classic EKG finding associated with cardiac tamponade is something called electrical alternans. It's just one of those buzzword things that's good to know. So electrical alternans means alternating electrical impulses. The QRS complex has beat-to-beat variability in amplitude. So one QRS might be really tall, the next one's really tiny, then tall, then tiny. So you have beat-to-beat variations in the QRS amplitude. It's pretty easy to spot. Now, electrical alternans is very specific to cardiac tamponade, but it's not very sensitive, which means that lots of people with tamponade don't have electrical alternans. If it's there, you can pretty much make the diagnosis of tamponade, but if it's not there, you can't rule out tamponade. I want to briefly mention the cardiovascular problems that syphilis can cause. Tertiary syphilis, when it affects the cardiovascular system, primarily affects the aorta. So syphilis disrupts the vasa vasorum, those blood vessels that supply the aorta. It can cause dilation both of the aorta itself and the aortic valve ring. Then dilation of that aortic root can lead to aortic regurgitation, but syphilis can also cause aortic stenosis. Syphilis can also cause thoracic aortic aneurysms and calcification of the aorta, and this classic tree bark appearance of the inside surface of the aorta. And then the last thing I want to discuss are some cardiac tumors. There are 3 main categories of cardiac tumors to discuss: metastatic tumors, myxomas, and rhabdomyomas. Now, cardiac tumors aren't all that common. The most common cardiac tumor is metastatic tumors from somewhere else. So we said a few minutes ago that melanoma likes to go to the heart, and lymphoma can also metastasize to the heart. But the most common primary cardiac tumor in adults is called a myxoma. Metastatic disease is the most common cardiac tumor overall, but if you're talking about primary cardiac tumors, myxomas are the most common. And myxomas usually occur in the left atrium, so I want you to remember the phrase left atrial myxoma. Put that all together in your mind. The left atrial myxoma looks like a little ball of tissue in the atrium. Clinically, this behaves kind of like a ball valve, and it can obstruct the mitral valve, and that can lead to syncopal episodes. So as blood is flowing into the ventricle during diastole, that myxoma ball is going to obstruct blood flow into the ventricle, which means that during systole, nothing's going to come out of the ventricle because you put no blood in there. So of course, that would cause a syncopal episode because you're not perfusing your brain. And then sometimes these myxomas can flop over into the left ventricle at the beginning of diastole, and that causes an early diastolic sound called a tumor plop. Now, I can't imagine they would actually expect you to recognize that sound on auscultation in your exam. Then rhabdomyomas are the other primary cardiac tumor, which is most common in children. So myxomas in adults, rhabdomyomas in children. And I want you to remember that rhabdomyomas are associated with tuberous sclerosis, along with astrocytoma, which is a brain tumor, and angiomyolipomas, which are renal tumors. So know those three tumors associated with tuberous sclerosis: rhabdomyoma, astrocytoma, and angiomyolipoma. So that's it for this video. Now it's time for the end of session quiz. So go over those questions and we'll talk through them together. All right, first question. Under what circumstances might you see pulsus paradoxus? So mainly I want you to think about cardiac tamponade, and rarely with pericarditis, but also think about asthma, croup, obstructive sleep apnea, and even severe COPD, anytime you have exaggerated inspiration. Next, what are the major criteria for the diagnosis of acute rheumatic fever? So the J was for joints, which is polyarthritis. The O is shaped like a heart for pancarditis. N is for nodules, those subcutaneous nodules. E is for erythema marginatum. And S is for Sydenham chorea, those choreiform movements in the face and the arms. And the last question, what heart pathology fits each of the following statements? So focal nodules of myocardial inflammation with multinucleate giant cells, those are the Aschoff bodies, which we saw in rheumatic heart disease. Chest pain and coarse rubbing heart sounds in a patient with a creatinine of 5 would be uremic pericarditis. Tree barking of the aorta is caused by tertiary syphilis. A child with fever, joint pain, cutaneous nodules 4 weeks after a throat infection is classic for acute rheumatic fever. ST segment elevation in all EKG leads is going to be seen in pericarditis. And EKG shows electrical alternans. Remember, that's very specific for cardiac tamponade, but we said it's not very sensitive. And then for the rapid fire facts, we have granulomatous nodules in the heart. Again, those are the Aschoff bodies, which we saw in rheumatic heart disease. The most common primary cardiac tumor in adults is a left atrial myxoma. The most common primary cardiac tumor in children is a rhabdomyoma. And the most common cause of constrictive pericarditis in the U.S., it's lupus. In developing countries, it's tuberculosis. All right, that's it for now. I'll see you next time.